Hi there. My name is Michele Schroeder. I'm an assistant professor of emergency medicine at Baystate Medical Center, and I'm also the associate fellowship director in emergency ultrasound. And I have the joy and privilege of being a almost career-long Baystater, doing my residency and fellowship here before staying on as an attending. So I'm happy to be here today representing Baystate Medical Center. And today we're going to be talking about ocular ultrasound. I don't, unfortunately, have any financial disclosures. We will be talking about ocular anatomy, go over the basics of the technique of ocular ultrasound, and then I'm going to go into a case-based demonstration of the common pathology. So eye complaints comprise about 3% of ED visits, and I don't know about you, but the fundoscopic exam for me is sort of the white elephant for me. It can be very difficult depending on patient cooperation, plus or minus whether you can find an ophthalmoscope in a time-sensitive period. So it can also be very difficult with severe trauma if there's a lot of periorbital swelling or bruising to do a good visual exam. So ultrasound is a great adjunct tool to your visual exam. So there's lots of things we can look at with the ultrasound. We can look for retinal detachment, vitreous detachment, vitreous hemorrhage, retrobulbar hematoma, lens dislocation, globe injuries in general, and assess for painless vision loss, as well as for intracranial pressure, and we'll talk a little bit about each of those in depth using case representations. So we'll start by going over the basics of the anatomy. What are you looking at on the ultrasound screen? And as you can see here, we have our diagram of the orbit on the left and then our ultrasound on the right, and you can see the corresponding structures between the two pictures. So the first thing we'll be looking at is the cornea. You can see the cornea on the ultrasound here represented by the red arrow. The lens is going to be just posterior to the cornea, then your vitreous chamber, your retina and vitreous layer, which is the posterior aspect of the eye, and then our optic nerve, artery, and vein, which run in the optic sheath. And it's important that you take a standardized approach when you're doing ultrasound of any type, but especially for the eye. It's such a small structure, and you're usually asking yourself a very specific question that if you're not looking at all of those structures in a very organized way, you can actually miss important pathology. So I usually start with the overall shape of the eye, then examine the lens. Is it where it should be? Is it the shape it should be? Examine the vitreous humor, the vitreous chamber. Look to see if there's any evidence of retinal detachment, then examine the nerves and vessels, and then finally the surrounding extraorbital tissues. As far as technique goes, it's pretty simple. There are two probes that will do a decent job of looking at the eye. The best option would be the linear probe. This is a very high frequency probe, so it gets you excellent resolution at shallow depths. And then the other option, if you don't have access to a linear probe, would be an endocavitary probe, which is also a high frequency probe. A little bit more awkward because you have a longer handle. So if you have the linear, that is your best option. You're going to have the patient in the supine position. You can use tegaderm as a barrier. So you're going to apply the tegaderm right over the patient's closed eye and then apply the gel over the tegaderm. You want to use lots and lots of gel, so you want to fill the depression above the orbit and make sure that you're stabilizing the hand on the patient. So this is what it looks like. On the left we have an intubated patient, and on the right we have one of our resident volunteers sort of demonstrating the technique. As you can see, you're going to apply the tegaderm over the eye as shown here, and then lots and lots of gel. Fill that orbit up with gel so that you're not putting too much pressure directly on the eye. And you're going to look in two planes. You're going to look in the long and short axis of the orbit. And remember, this is a kinetic exam, so you want to have movement with the eye. You want to have the patient moving their eyes left and right, up and down. That allows you to examine all quadrants of the eye and improves identification of your pathology. You can also assess extraocular movements and pupillary dilation, which we'll talk about a little bit later with a kinetic exam. You can also use color Doppler to assess for vascular sufficiency to the retina, so looking at the central artery and vein in particular, and we'll go over that a little bit later. All right, so if there's no questions so far, we'll go ahead and start with a case. So we have a 36-year-old obese African-American female with headache and vision changes. The headache has been about 10 days. It's located frontal and retroorbital and worsens when she moves her eyes. For the past 2 days, she started with blurred vision, and then this morning she had a brief episode of complete blindness while she was bending over to tie her shoes and decided it was finally time to come in and get evaluated. On exam, she has 20/70 vision in both eyes, and of course the fundoscopic exam is very difficult for multiple reasons. So we're going to take a look with ultrasound, and this is what we see. So again, you want to do your standardized approach, so the overall shape of the orbit, it looks round, it looks appropriate. You're going to examine for the lens, which is just out of view in this picture, but make sure that you're looking for your lens. Examine the vitreous. Is there anything there that shouldn't be? Are there any signs of retinal detachment? It looks good to me. And then we're going to look at that optic sheath. And what you'll see here is what's called optic disc cupping, where you get protrusion of the optic disc into the vitreous chamber. And you're also seeing optic sheath diameter enlargement. And both of these things are a sign of papilledema. And the two things you're looking for on ultrasound are the optic disc cupping and increased optic sheath diameter. So for disc cupping, you're looking for a height greater than 0.6 millimeters. You heard that correctly, 0.6 millimeters. It's a very narrow margin between normal and abnormal, which is one of the limitations of this exam. And why it's only 82% sensitive and 76% specific. And there are lots of other things that can cause optic disc cupping. Central retinal artery or vein occlusion, optic neuritis, and congenital conditions are all things that can cause optic disc cupping. So if you see it in the absence of symptoms, it's probably just incidental. And this is what we're looking like for measuring the optic disc cupping, excuse me. The next thing we're looking for is an optic nerve sheath diameter greater than 5 millimeters. And you're going to measure the diameter 3 millimeters posterior to the retina. And this has about an 88% sensitivity, 93% specificity for an intracranial pressure over 20 millimeters of water. And again, the drawbacks are that these are very small structures with very narrow margins for normal versus abnormal. And so there is a little bit of operator dependency, right? So depending on which pixel or two you choose versus what I choose, we can have a normal result for one person and abnormal for another. So there are some limitations. Make sure you take the clinical exam into play. And I wouldn't suggest that ultrasound replace other gold standard imaging techniques for diagnosis of increased intracranial pressure. All right, and this is an example of how we're going to measure the optic sheath. So again, you're going to first measure 3 millimeters posterior to the retina, and that's where you measure the diameter. In this case, the diameter is 5.9 millimeters, so above that 5 millimeter cutoff. All right, moving on to our next case. We have a 65-year-old with a history of diabetes presenting with vision loss. Started with a small area of black the day before arrival and slowly progressed to include her entire field of vision in the right eye. There's no pain, no fevers, no headaches, and no history of contact use. And here's our ultrasound. And what you're seeing here is a hyperechoic linear structure that moves with the orbit. And this is a classic representation of retinal detachment. Again, your textbook presentation is sudden painless vision loss with photopsia or flashes of light, floaters, and then a curtain of vision loss that descends over the visual field. ED ultrasound has a fantastic sensitivity, 97%, 88% specific, and this is largely due to confounding vitreous detachment with retinal detachment. We'll go over that a little bit later. But the sensitivity is excellent. There are 3 different kinds of retinal detachment. Rhegmatogenous is caused by shrinking vitreous that results in a tear in the retina. Tractional is where the connective tissue creates tractional forces, so the retina remains intact but detaches from the posterior part of the eye. And exudative, where you get fluid buildup underneath the retina, and this is largely in the setting of inflammatory conditions. As far as ultrasound goes, these are all going to look very similar. So you're looking for a highly reflective linear structure that moves with the eye. And the most important part is that it's tethered at the optic nerve. So you can see here the red arrow is going to point to the optic nerve as it comes into view there. And then you can see that the retina is tethered right there at the optic nerve. And that's very important for distinguishing between retinal detachment and vitreous detachment. I'll show you a couple more examples. Here's another retinal detachment, and you can see that it is tethered at the optic nerve. It's another one, again, that tethering, really important. And it's important that you fan all the way through the orbit to look for that tethering. If you're just out of plane of where the tethering is, you might mistake it for lack of tethering. One more final example here. So treatment is surgical. The urgency varies, and I think over the last few years the trend has been that it's less of an emergent fix within 1 to 2 days in general. And if there's macular involvement, the urgency might be even a little bit less. So if your macula is still intact and you still have central vision, then fixing the problem might be a little bit more urgent so that you can save that central vision. All of these are going to require some ophthalmology consult. All right, moving on. We have a 75-year-old female with 2 days of left vision changes. She describes floaters and mild photophobia. Her vision is 20/40 on the right and 20/50 on the left. And here's our ultrasound. So again, we're seeing a linear hyperreflective structure. It is moving with the orbit. But this is an example of vitreous detachment, and we'll go over why this is a little bit different from retinal detachment. You might be saying to yourself, wow, that looks remarkably like a retinal detachment. And I'll go over what the differences are. So vitreous detachment is usually painless and abrupt. Patients will usually complain of floaters or photopsia. It typically does not threaten vision significantly because the retina remains intact, and it occurs more often the older that you get. It's typically a C-shaped linear hyperechoic structure that's typically thinner than you would see with a retinal detachment, and it is not attached to the optic disc. So we'll look at that clip one more time, and here you can see clearly the optic disc, the optic sheath here, and it is not tethered there. So that is suggestive of vitreous detachment. Now, as a caveat, especially recently, again, the urgency for retinal detachment repair is less so than we used to think. And so the follow-up or the plan for both vitreous and retinal detachment is the same. You're going to get your ophthalmologist involved, and typically it'll be outpatient follow-up within a day or two for both. So it's not the end of the world if you're not sure if it's a vitreous or retinal detachment. All right, moving on to our next case, we have a 75-year-old female with 2 days of left vision changers. She describes floaters and mild photophobia. Her vision is 20/40 on the right and 20/70 on the left, pretty similar to our last case. And here's the ultrasound. So what you're seeing here is hyperechoic substance within the vitreous chamber that moves with the eye. And this is a classic example of vitreous hemorrhage. So vitreous hemorrhage occurs when there's bleeding from vaginal vessels in the vitreous space. Risk factors include diabetes, trauma, and retinal tears. And again, patients will complain of floaters, flashes, cloudy vision, and typically no pain involved. The appearance depends on the age and the severity of the hemorrhage. Here's another example of, this is with vitreous detachment with hemorrhage. So you'll see a hyperechoic linear line not tethered there, as well as some hyperechoic substance that's floating in the eye. And this is made more obvious when the patient moves their eyes left and right as you're ultrasounding. Here's an example of a retinal detachment with vitreous hemorrhage that's anterior to it. So there's that hyperechoic linear line that moves with the eye. Posterior to that is that hypoechoic space. That represents the detachment area of the retina. And then anterior to that, you see that hyperechoic substance that's moving with the eye. That's the vitreous hemorrhage. So a nice example of 3 different kinds of pathology here. This is typically what you'll see with vitreous hemorrhage. You'll see this fibrinous hyperechoic material that moves with the eye. And as the vitreous hemorrhage ages, it will organize into bands, so you get a little bit more of this band-like appearance the older the hemorrhage is. All right, moving on to our next case. We have a 78-year-old male with a chief complaint of sudden painless vision loss in the right eye. The EKG shows new onset atrial fibrillation. On exam, the patient can see your hand moving in distinguished shapes, but can't read any line in the visual acuity testing. You are able to achieve a beautiful fundoscopic exam on this patient, and this is what you see. So we have on the right here an example of a normal fundoscopic exam, and on the left is our patient. And you can see that there's marked pallor of the retina there. And this is pretty classic for central retinal artery occlusion. So typically, again, painless vision loss may be partial or complete, especially if it's a branch of the central retinal artery that's occluded versus the main. It's considered a form of embolic stroke. And when you're doing your ultrasound, you should be able to see both arterial and venous flow present. When you're assessing, you need to use 3 different kinds of Doppler: color, power, and pulse wave Doppler, and we'll go over those briefly. And it is important with these patients that you get an EKG to look for that new onset AFib. So on the left here, we have our color Doppler, and you can see the range here on the left is 13 to -13. It's important that you bring those numbers lower rather than higher so that it'll pick up low flow states only. And on the right here, we have power Doppler. So you can see that you're losing your information about directionality of flow, but this is a little bit more sensitive. It's a little bit more able to pick up slow flow states. So here we have our normal orbit on the left here, and then this is our patient on the right, and we're using our power Doppler here to pick up these low flow states. And you can see on the left that there is flow, and we're not seeing any pulsatile flow on the right. All right. Moving on to our next case. We have an 80-year-old male in the ED for abdominal pain, a super motivated resident who wants to complete all of her exams while rotating through the ultrasound rotation. Asked this patient if she can ultrasound his eye. And he says, sure, I'm waiting around a few hours for my CAT scan, why not? And this is what we see on the ultrasound. So this looks similar to something we've seen before, right? So we see this hyperechoic material in the vitreous chamber that moves with the movement of the eye. But what's different in this patient is he has no ocular complaints, completely asymptomatic. His vision is baseline in both eyes, 20/40, and the remainder of his ocular exam is unremarkable. And this is a great example of vitreous bands. So these are asymptomatic presentations, usually age-related. The older you are, the more likely you are to see these, typically bilateral, and often associated with things like diabetic retinopathy, a history of vitreous hemorrhage, sickle cell disease, prematurity, and it's more easily seen with a higher gain on your ultrasound. So don't be surprised if you see those, and they're often incidental. If the patient has no symptoms, there's really not much you need to do for that. Moving on to our next case. We have a 45-year-old who tripped and fell, hitting his right eye and forehead on a dresser. He reports being able to see light and dark, but otherwise nothing is distinguishable. He has a very mild headache and has some significant periorbital bruising, which makes your direct exam of the orbit difficult. And this is what the ultrasound looks like. So again, if we're going to go through our algorithm of how to assess the ultrasound, we're going to assess the shape of the orbit first. It looks round. I don't see any signs that I would be concerned, for example, for a globe rupture. Next, we're going to look for the lens. Well, that's interesting. The lens isn't where it should be. And if I then proceed to look at the vitreous chamber, there's something in the vitreous chamber that shouldn't be there. And this is actually the patient's lens, which has been dislocated and is now floating in the posterior, in the vitreous chamber. So this is, again, an example of lens dislocation, very easy to diagnose with ultrasound, most often associated with trauma, but can be associated with things like connective tissue diseases, recent cataract surgery, or nearsightedness. You can have both anterior or posterior dislocations, and you can assess for both of those with ultrasound. Of course, the difference between the two is that the anterior dislocation is more likely to cause acute glaucoma, and so might be a little bit more time-sensitive repair. If you can assess the patient visually, this is what you might see. So on the left here, the arrow is pointing to the lens, which is clearly this strange structure that you're seeing in the pupil there. And then in the right, it might be even a little bit more obvious, and these are partial dislocations, so you're still seeing part of the lens. Here's another example. This is a partial dislocation, so there is some tethering still of this lens to where it should be, but obviously it's the wrong shape. It shouldn't be circular in this view, it should be elliptical, and it's descending down into the vitreous chamber. And here's another example. All right, moving on. We've got a 25-year-old in a high-speed motor vehicle crash with bilateral periorbital bruising and edema. Because of the degree of bruising, you're unable to actually visualize the orbits directly, and to make it even more difficult, the patient's intubated, so you can't really ask him about any visual complaints. So you're going to use your ultrasound, and when you look at the eye, it looks like this. So the shape is not perfectly circular. It looks a little bit irregular. The lens, I think, is visible, although I'm not sure it's in the right place. And then the vitreous chamber is filled with this hyperechoic substance. And this is an example of globe rupture. So with globe rupture, you will get a loss of intraocular volume and height, and that's what makes the shape less circular. We call that a flat tire sign. And you will see intraocular echogenic material or sometimes air. Here's another example. And in this example, this was a patient who ended up with a needle in his eye. That's that hyperechoic linear structure there is a needle. And you can see that, again, the orbit has, it's a little unclear how the needle got there. But so, again, you can see you get loss of that perfect circular appearance, and you're seeing other hyperechoic stuff within the eye, and that's all air that's been introduced because of the needle. All right, gold standard is orbital CT for globe rupture. And remember that ultrasound is relatively contraindicated. So especially if you're working under an attending, make sure you talk with the attending first before doing the ultrasound. And if you decide to proceed with the ultrasound, do it very cautiously. Make sure you're not putting any pressure on the eye at all. All right, moving on. So again, we have a 25-year-old in a high-speed MVC with bilateral periorbital bruising and edema. You still can't visualize the orbits, and again, the patient is intubated. All right, and here's our ultrasound. So similar story, but I'm giving you a little bit of different pathology here. And this is an example of a retrobulbar hematoma. So again, going through our algorithm, the orbit itself appears circular, the lens appears to be in the correct place, the vitreous chamber looks clear, I don't see any retinal detachment. Now we're going to move on to look at the tissues surrounding the orbit, and you can see there's this hyperechoic structure that's not in the location where you would typically see the retinal or the optic nerve, and this is a retrobulbar hematoma, which is important for us because it causes increased orbital volume and pressure, which is basically a compartment syndrome of the eye and requires emergent surgical treatment. On exam, you might see some proptosis, you'll definitely have acute vision loss, an afferent pupillary defect can be seen, and you'll have an increased intraocular pressure. And of course, this is a surgical treatment, so we're going to proceed with a lateral canthotomy. This is one of my colleagues at Baystate performing a lateral canthotomy on a patient. All right. Then we'll quickly talk about some miscellaneous cool stuff that you can see with ultrasound, and these things are typically things that you might find incidentally but are interesting. One of the things that is useful is that you can assess for pupillary light reflex using ultrasound, and what you're going to have to do is have the patient look straight down towards their feet, and you're going to angle the ultrasound probe almost parallel to their body. So you're looking down through the orbit as they're looking down, and you're going to hit the pupil in axis like this. And then if you shine a light in the other eye, you can look for a consensual reflex like this. So see the pupil constricting and dilating. So it's a nice way to assess for light reflex for patients who are uncooperative with the exam or who have too much periorbital edema or bruising. Here's another example of pathology you might see, not as common, but you're seeing a hyperechoic mass in the vitreous chamber. And this is an example of retinoblastoma. Right, here's another example of something that you might see from time to time. So again, our orbit here is on the left-hand side of the screen being cut off a little bit, and we're seeing this hypoechoic structure that's just to the right of the orbit. And this is a retrobulbar abscess, and this is the corresponding CAT scan to the patient. So you can see there in that patient's right eye that you're seeing this large abscess that's causing pressure on the orbit as well. This is a case of pan-uveitis, so you're seeing inflammation of all three layers of the eye. So you can see here how thick the retina and the other layers appear compared to our normal on the right. You can also see there's some hyperechoic material within the orbit itself suggestive of infection. All right. So go forth and ultrasound. Ocular ultrasound is a very easy skill to develop. Like anything else, it does take some practice, but it's one of the more technically easy studies to do. It can dramatically improve your diagnostic accuracy, especially if, like me, the fundoscopic exam is the bane of your existence. and will facilitate ophthalmology consults for time-sensitive emergencies. So thank you very much, and I look forward to meeting some of you in the future.
Well, that was a great talk. Thank you so much. I feel a little challenged by some of the different things that you're talking about. Can I ask you a couple of quick questions?
Absolutely.
So one was, you mentioned the time-sensitive version of retinal detachment would be the macula on versus macula off, which
Correct.
macula off would have to go to ophtho earlier. Are you able to tell with the ultrasound if it's mac off, or is this purely based on their exam and loss of that central vision?
Yeah, that's a great question. So the exam with loss of central vision is going to be a little bit more helpful, but you can look, again, the macula is going to be in the temporal portion of the retina, so you can look and see if the detachment is overlying that area. That would be more suggestive that you're macular off, versus if you're seeing the tethering on the non-temporal side, that would be suggestive of possibility that you can still save that person's central vision.
That's really cool. One other question. So you mentioned for retrobulbar hematoma, which often we go for CT, which can be a bit of a wait, and occasionally we'll even try and go and do the lateral canthotomy just based on a high pressure, but sometimes your tonneau pen has gone wandering. How good is the ultrasound for retrobulbar hematoma?
Yeah.
If it's not there on the ultrasound, like how good of a rule out is that?
Another great question. There's not a lot of great evidence about it because it's not a very common injury, and on top of that, like you said, we typically go with CAT scans and other imaging studies first. So there's not a lot of great evidence about that, but it would be an interesting thing to study in the future.
That'd be a great study to do. Well, thank you so much for answering my questions.
You're welcome. Thank you for having me.